Kidney cancer, also called renal cell cancer or renal cell adenocarcinoma, is one of the most common and devastating forms of cancer, and while it, alongside other cancers, may seem incurable, there are several important things to note about its causes and potential treatments. Common risk factors for kidney cancer include old age, peaking around someone's 60s or 70s, smoking, obesity, high blood pressure, treatment for kidney failure, certain inherited syndromes such as von Hippel-Lindau disease, Birt-Hogg-Dube syndrome, tuberous sclerosis complex, or hereditary papillary renal cell carcinoma, as well as family history connected to renal cell cancer or kidney cancer. Kidney cancer is a disease that is caused by the growth of large lipidous masses of cancer cells called tumors on one or both of the kidneys. Large rounded portions can form in at least one of the kidneys as a result, leading to bleeding and cysts which contain watery fluids forming around the deceased kidneys. The tumor itself is usually comprised of many large blood vessels that contain tumor cells in its walls. Other symptoms include urine turning pink, red, or dark brown from blood mixing in it, back pain that doesn't go away, loss of appetite, weight loss that can't be explained, feeling tired, secondary tumors appearing in the lungs, liver, brain, or bone tissue, as well as having a fever. The cancer is often not immediately recognized in the early stages until it spreads to other parts of the body in the later stages. It is also only around the later stages that pain will be felt from the cancer. This is because it isn't felt early on, and symptoms like painless bleeding will likely be ignored or disregarded by the person afflicted with the cancer. Despite that, kidney cancer is often discovered early on when the mutated cells are still confined to the kidney and only make up a small portion of it. However, kidney cancer can still be fatal if allowed to spread throughout the body, but there is a 52% chance of survival for 10 years or more with the proper treatment.
Cancer is the uncontrollable division and replication of cells, resulting in a large mass called a tumor. Normally, cells divide in three phases: interphase, mitosis, cytokinesis. This process normally goes something like this. Interphase is the part of the cell's life cycle which it spends the most time in, pre-division. It happens in three phases. First is G1, or growth 1. This is where the cell grows and matures. Next is S phase, or synthesis, where DNA is replicated for cell division. And finally, there's G2, where a cell continues growing before eventually dividing. Mitosis is the actual process by which cells divide, which occurs in four phases: prophase, metaphase, anaphase, and telophase. Prophase is when the cell's DNA is organized for the later parts of the cycle in mitosis. First, the nucleolus is removed around the DNA for easier transport. Then the cells must condense the DNA, found as long loose strands called chromatin, into protein and DNA structures called chromosomes. The nuclear membrane fully dissolves at the end of prophase, allowing the chromosomes to enter the daughter cell. Metaphase is the quote-unquote middle phase of mitosis. This is where the chromosomes are lined on the middle of the cell, the equator or the metaphase plate. This process occurs when spindle fibers, protein structures that will later tear the chromosomes apart in anaphase, line the chromosomes on the metaphase plate at the centromeres. The chromosomes are made of two sister chromatids. Chromatids will later become chromosomes when these chromosomes split up. The chromosomes are split apart by the spindle fibers. The spindle fibers pull at the centromeres, the chromatids go to the opposite poles of the cell, and now become daughter chromosomes. This process is anaphase. Finally, telophase is when the nuclear membrane and nucleolus form again, and the chromosomes unwind back in the chromatid within the cell. Cytokinesis is the end of cell division, which results in two new daughter cells. Two nuclei are formed within the cell. The sides of the cell pinch in, forming two brand new daughter cells, and they split apart. The process of interphase, mitosis, and cytokinesis is known as the cell cycle. There are two main ways that cancer can spread rapidly throughout the body, through a process called the cancer cycle. The first problem comes down to checkpoints. Cells have checkpoints to make sure the cell is growing and maturing at the right rate and doing all its functions correctly before dividing. If any cell is flawed in some way, such as carrying mutated DNA that's beyond repair, it is forced to kill itself in a process called apoptosis, programmed cell death to prevent that flawed form of the cell from spreading throughout the body. In some cancers, these cancer cells can skip the checkpoint. Even though they're flawed and extremely dangerous, they can avoid apoptosis. And since it quote-unquote passed the checkpoint, it's avoided by the immune system, who won't attack it. Another reason cancer can grow extremely fast, besides passing a checkpoint, is that the cancer can secrete growth hormones. These growth hormones provide plentiful amounts of nutrients and take them away and hoard them from other cells that are healthy. The cancer cell can grow extremely quickly, go through all the stages of the cell cycle extremely quickly, and divide very quickly, which allows it to spread to other parts of the body. Cancer can be attained in two ways, either through environmental factors or the alteration of genes, which is considered a mutation. In most cases of kidney cancer, which a gene is mutated, three tend to be most common: VHL, PBRM1, and TTN. Here's a chart showing the frequency of each mutation. VHL is the gene that gets the most mutations in kidney cancers, 31% of the time. It's a special type of gene known as a tumor suppressor gene. These genes code for VHL proteins, which can stop potentially cancerous cells from growing in numbers by signaling for apoptosis, the self-destruction of these cells. If this gene is mutated, it can result in a complication known as VHL syndrome, a disorder that has to be PBRM1. VHL syndrome is the most common way for known to code for the protein polybromo-1. This protein manages the passage of tumor protein p53. This protein helps limit the amount of times a cell divides within the kidneys. When PBRM1 is mutated, the p53 proteins have limited axis of travel. This makes mutations in PBRM1s an extremely common cause for kidney cancer. More will be discussed in the atlas. TTN is the next gene, interestingly, a checkpoint gene, as discussed earlier in how cancer can spread. TTN codes for the protein titin, which basically manages how a cell is doing and signals for apoptosis whenever a cell is missing the points for a checkpoint. Now we'll look at the specific mutations found for each gene. So we'll start with VHL. There are mainly three kinds of mutations you should take away from this: missense mutations, splice mutations, and nonsense mutations, whose functions we've gone over before. The nonsense mutations resulted in a W88 protein being formed. The missense mutations tended to be more variant. The next mutation was the missense mutations. These proteins included L158V, V74D, and C126R. Splice mutations resulted in X14_splice and X155_splice proteins. As mentioned previously, the VHL gene should normally code for the protein VHL, whose full form is von Hippel-Lindau protein. The protein, of course, signals for apoptosis in a cell that's been severely damaged and poses a cancerous to the body. In other words, it's also like a checkpoint, like the TTN gene. Mutations that block the creation of this basically open the gates of the checkpoint. Damaged cells can just simply pass it, or quote-unquote pass it. They don't actually pass it, and continue to grow and spread throughout the body. Next is the PBRM1 gene. There are mainly four kinds of mutations: frameshift deletion, frameshift insertion, nonsense mutations, and splice mutations. These varied very much. Splice mutations provided a variety, but mainly X856 splice, X5114 splice, and X1267 splice. Frameshift deletions made proteins K53RFS *16, Q99RFS *3, and S498AFS *2. Frameshift insertion made H5Z3LFS2 and I279NFS *3, amongst others. Nonsense mutations coded for Y697, R710, Y1568, and R434 proteins. A lot of these protein significances are unknown, but PBRM1 normally codes for polybromo-1 protein. This protein manages the passage of tumor protein 3 and prevents a cell prevents a cell from dividing too many times to the kidneys. Of course, when this is limited, the cells can divide basically as many times as they want. Finally, we have the TTN gene. Now, the TTN gene had the most mutations, 6 types: missense, nonsense, frameshift insertion, frameshift deletion, in-frame deletion, and splice mutations. So the missense mutations coded for T34730I, P7323R, K3424-2R, and A16A2AS proteins. So the nonsense mutations coded for proteins Y23897 asterisk, W18832 asterisk, and Y138 asterisk. Frameshift deletion didn't have a lot. It had R31856VS asterisk 13 and E6759SFS asterisk 11. So those were the only two that were found with the frameshift deletion. Frameshift insertion also didn't have a lot, only mainly two. T6200 HFS asterisk 15 and E33020 asterisk proteins. So in-frame deletions created 3 proteins: E13529 del, L13170 underscore V13171 del, and K11894 underscore K11895 del. Splice mutations had the least amount of mutations, only one major one, K1247 protein. Now, all these proteins take up the place of the titin protein, which is normally made by the TTN gene. This protein is a checkpoint, and it makes sure that cells follow the necessary steps of maturity before moving on to division, and it signals apoptosis in those who fail to meet the checkpoints. Cancer cells can evade the checkpoints with the TTN gene mutated. Kidney cancer is usually detected through screenings called CT scans and MRI scans. These scans are effective, but can't tell the difference between benign and malignant tumors in the kidney. As a result, it's hard to exactly judge what kind of tumor it is, or what kind of cancer it is, from these scans alone.
Some treatment options for kidney cancer are surgery, cryotherapy, radiotherapy, and renal arterial embolization. First, surgery. Surgery is the main treatment option when kidney cancer has not spread to another part of your body, and the surgeon may have to remove part or the whole kidney. Surgery can remove cancer that is completely inside the tissue, or if it has spread into nearby tissues. Surgery may not be able to cure or stop cancer, but it can be used to control its growth and relieve some symptoms. Cryotherapy. Cryotherapy is when your doctor puts small needles into the cancer. Cold gas is put down the needles to freeze the cancer cells, which kills the cancer cells. Cryotherapy is used to treat small and early stages of kidney cancer that are less than 4 centimeters across. The main target for this type of treatment is to cure or remove kidney cancer without removing part or the whole kidney. Radiotherapy. Radiotherapy uses high-energy X-rays to kill cancer cells. This type of treatment is used for advanced kidney cancer. Kidney cancer is less sensitive to radiotherapy than some other types of cancer. Radiotherapy is used to control kidney cancer's growth if surgery isn't available. To treat kidney cancer that has spread into other areas and to relieve symptoms. Renal arterial embolization. Renal arterial embolization is a treatment for kidney cancer by blocking the blood supply for kidney cancer. Our blood carries oxygen and nutrients to cancer so that it can keep growing. However, if a doctor or surgeon can stop the blood supply to the cancer, then its growth may slow down. Global distribution. Kidney cancer is more common in older people. This type of cancer is found in people between the ages of 65 to 74. Kidney cancer is also twice as common in men than in women, and it is more common in African Americans, American Indians, and Alaska Natives. Only the United States and China hold the top spots for the most cases of kidney cancer.
The first clinical trial was conducted in the UK in London, which was a dose escalation study investigating everolimus and definitive in metastatic clear cancer. Metastatic kidney cancer, or when kidney cancer spreads past the kidney, is extremely hard to treat, and many patients die within 3 years of this stage of cancer. However, attempts are being made to combat this. In 2006, a tyrosine kinase inhibitor called sunitinib came into fruition and is a treatment that has become standard therapy for patients. The objective of this drug is to prevent the new blood vessels within the cancer from developing. The body's initial response to the drug is impressive. However, after 11 months, the body develops a resistance to the drug and many patients end up dying anyway. However, it has now become standard practice to switch to the drug everolimus when resistance to sunitinib occurs. That being said, the average time to progress with everolimus is 4 months for patients previously treated with the drug, so as a result, even more improvement in treating patients is needed. The most effective way of making everolimus more potent is implementing agents that will attack the sunitinib resistance directly. A new promising drug for renal cancer, noticed from the pharmacology data based on a variety of vitro and vivo studies, is definitive. Certain cellular functions such as the activation of downstream signaling molecules, cell proliferation, and survival are blocked as a result of definitive to combat renal cancer. The combination of everolimus and definitive is extremely promising, as it will target the 3 major catalysts connected to the growth of the tumor. However, these two drugs haven't been used together as a combination, and even though each drug has safety data, there is no data in regards to the safety of using them together as a combination. As a result, a clinical trial was made to figure out the maximum tolerated dose for definitive and everolimus as a combination for renal cancer, with 30 patients recruited to participate. A study established a maximum administered dose and maximum tolerated dose. The MTD was with cohort 0, having 5 mg of everolimus and 200 mg with definitive. In cohort 0, 6 patients were recruited, and only one of those 6 patients experienced a dose-limiting toxicity. For the expansion phase of MTD, 7 assembled patients in total were recruited for at least the next 6 months to solidify the safety, tolerability, efficiency, PK, and biological endpoints. The next clinical trial was conducted in France in both Dijon and Pierre-Bénite for stereotactic radiotherapy for renal cancers. Stereotactic radiotherapy is a technique that allows for a high dose of radiation over a few fractions extremely precisely. Stereotactic radiotherapy allows for tumor ablation, which is used in an attempt to shrink or destroy the tumor, as well as the ideal preservation of healthy tissues. It was revealed that high doses of radiation allow for local control in 90 to 98% of cases of stereotactic radiotherapy for brain metastasis of renal cancer. A phase 1 study for tumors of less than 4 centimeters was proposed by investigators. Similar to how they perform in treating lung cancers, stereotactic radiotherapy can provide a method for treating renal cancers with a high rate of local control while still being non-invasive, painless, and a rapid method up to 4 to 5 fractions. The main objective of this clinical trial is to find the MTD for 1 fraction in stereotactic mode of renal tumors greater than or equal to 4 centimeters in length using a 4-step dose increase. Step 1, 4 by 8 grays. Step 2, 5 by 8 grays. Step 3, 4 by 10 grays. Step 4, 4 by 12 grays. The patients taking part in the clinical trial will be monitored during the treatment with an examination of acute toxicities prior to every session. Then, at 15 days, which will become 6 weeks, 3 months, 9 months, 12 months, and then finally eventually 6 months for a total duration of 5 years after treatment.
The last clinical trial was performed in Oxford, England, United Kingdom for Bryostatin 1, a drug used in chemotherapy to slow down the growth of tumor cells or to kill them. The objective of this trial is to determine the response rates in patients with progressive hypernephroma treated with bribes.